everyone. My name is Caitlin Bafis-Lasky, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all today to our educational webinar hosted by Lymphoma Canada at our national conference on chronic lymphocytic leukemia. We appreciate those of you able to join us live today to learn more about the disease-specific biology of chronic lymphocytic leukemia, and we will examine the current Canadian treatment options available and highlight treatments coming to Canada and the research and results behind these new therapies and clinical trials. Now, before I go ahead and introduce today's speaker, I'd like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or microphone. But if you do have a question, please save it for the CLL Q&A session following this breakout presentation. You can then ask your questions to the presenter live. I would now like to introduce and welcome our speaker, Dr. Banerji. Dr. Banerji obtained her undergraduate degree and clinical training in medicine in hematology from the University of Manitoba. She completed additional training in translational research at the Dana-Farber Cancer Center and the Broad Institute of Harvard and MIT. She is the co-lead of the CLL Clinic at Cancer Care Manitoba and the University of Manitoba. Dr. Banerji is a principal investigator for lymphoma clinical trials and has a focus on the diagnosis, prognosis, and treatment of CLL. We thank you very much for joining us today to speak on this lymphoma subtype, CLL, and we would like to now turn over the presentation to you, Dr. Banerji. Thank you, and you can take it away.
Thank you, Caitlin. Good afternoon, everybody. Thank you very much for joining us today. The first thing I wanted to do was introduce the cell type from which this cancer is derived. So if we think of the blood system, it is a very complicated system that starts with what we call a hematopoietic stem cell, which is capable of renewing itself. So when we look at blood under the microscope, this is what it looks like. We have a collection of different types of cells all living harmoniously together. So there are red blood cells, white blood cells, which are the larger formats over here, and these can be divided into further subtypes. And the one of interest for this talk is what we call a lymphocyte. But other cells are also required to help fight infections, but also to understand the balance that is required to maintain a healthy blood count. So the other cells that are of importance are the neutrophil over here and the platelets over here. So the neutrophils are bacteria-fighting blood cells, and the platelets are a subtype of cell that help us form clots. But what happens when we develop chronic lymphocytic leukemia is that we start to get an overpopulation of a specific abnormal white blood cell known as the CLL lymphocyte or SLL lymphocyte. And so there starts to be an increased number of these cells in the peripheral blood or the bone marrow or the lymph node, depending on which tissues you have that are affected. And so often we start to see changes in the blood counts as a result of the change in this balance. So chronic lymphocytic leukemia belongs to a spectrum of lymphoproliferative disorders, i.e. growth of a lymphoid cell. And so patients can be classified into one of three categories, or it can continue through a spectrum of any of these categories. So monoclonal B-cell lymphocytosis is what we call a precursor to one of these abnormal cancers. It's when you have these uniform cells that carry a CD19, a CD20, and a CD23 marker on their surface in addition to a CD5 cell. And what's important is that the level of these uniformed B cells in the blood are less than 5 × 10⁹ per liter. In chronic lymphocytic leukemia, these cells are greater than that threshold. Small lymphocytic lymphoma is a situation in which the blood count is not high enough to meet criteria for CLL, but people may have had a biopsy of a lymph node or a abnormal blood count or a positive bone marrow test in which these uniform cells are found. So who does it affect? There is approximately 2,600 new patients diagnosed each year, and the average age at diagnosis is around 72. It's more common in men than it is in women. We do not have a cause for why this occurs, and it's considered an incurable cancer. We often observe these patients over a period of time, and at the time of progression or symptom development, we would talk about treatment. So what happens in this situation is the bone marrow is creating this abnormal population of cells, which then flow and spill into the bloodstream and travel and populate the lymph nodes as well. So what's happening is that in the normal situation, you have a balance of cell survival and cell death. The CLL cell or the SLL cell, that balance is disrupted. And we tend to have increased cell survival, increased cell growth, and less cell death, which is why these cells accumulate in all the different tissues. So this is often what a white blood cell, no matter how high the white count gets at this point in time in this particular disease. What's concerning to us is the rate of change of the white count. Typically a doubling time of less than 6 months, with changes in the hemoglobin and platelets is of particular concern. So that's how we determine part of the staging system. So anyone who has a very high white blood cell count would be considered a RYSE stage 0, so anything over the threshold. RYSE stage 1 would be the presence of lymph nodes. RYSE stage 2 would be presence of a palpable spleen. So I could feel your spleen on physical exam. And RYSE stage 3 and 4 is a sign of bone marrow infiltration. So on the bottom, we have here normal images of what the bone marrow looks like. So it's a mix of cells being produced with fatty spaces in between. But what happens when patients develop CLL is that we disrupt the normal architecture of the bone marrow, and this can result in an overcrowding, as I spoke about earlier, of the abnormal white blood cells in this space. And so we get a reduction in the production of the red cells and the platelets. And this results in RYSE stage 3 if your hemoglobin is less than 110, or RYSE stage 4 if your platelet count is less than 100. So as I mentioned before, this is the staging system. So when it was first reported back in the 1970s, the staging system had a significant reduction in the prognosis of RYSE stage 3 and RYSE stage 4 patients. But recently there has been a publication from the Mayo Clinic looking at the improved survival of these patients. This represents 3 different factors. One is that we're better at selecting true bone marrow infiltration. So if you read a lot of literature that might be found on the internet or different reading materials that are available, there's lots of different prognostic markers that are there to help predict your outcome. And so these include age, sex, lymphocyte doubling time, changes in the genetics or the chromosomes of your CLL cells, as well as certain markers on the cell surface. So one of the things besides the RYSE staging that we use to predict outcome are a series of different markers known as prognostic markers. They can help predict your outcome. And this includes the staging as we talked about, but age, sex, lymphocyte doubling time that I've mentioned previously, genetic abnormalities, certain markers that may not be tested in every lab, but are often reported in research papers, as well as other things that are biochemistry tests that we can do on your routine blood tests, and some things that people might not often think about, such as vitamin D. So we talked about advanced stage having an inferior prognosis. Greater age, greater than 75, is typical, have lower prognosis. Male sex, lymphocyte doubling time less than 12 months, but definitely less than 6 months is often quoted in the literature in the recent past. and then different genetic abnormalities that we'll talk about in the next few slides. If your body is unable to clear certain drugs, that decreases your ability to have certain treatments. And that was especially true in the era of chemotherapy, but that is changing as drugs are often metabolized differently nowadays. The one thing to note is that vitamin D has been shown to be a prognostic marker. And so as a physician, the things that I want to ensure my patient takes away is that we're not to do any harm to the patient. We're trying to preserve their quality of life as much as possible. And so we know that this is a disease that is treatable, but at this point in time, we do not know if it's curable. And I would have said it's not curable probably 5 years ago. But as treatments are evolving, that the definition of cure may be attainable, but at this point in time, we don't have all the data or the long-term data required to say that. So because of the incurable nature of this disease, especially in patients who are older and maybe frailer, our focus is on quality of life. But this happens by us actively observing our patients so that we don't miss the time point at which treatment is required. And when treatment is required is due to the fact that the disease is progressing and altering different functions that those cells would do in a normal format. So one is recurrent infection. Two, it's altering how you feel. You might have fevers, chills, night sweats, tiredness, and these are all things that are typical of cancer symptoms and can also be seen in CLL. Tiredness is the #1 symptom that patients do disclose with their CLL. Rye stage 3 or 4 disease, or advanced stage disease, secondary to bone marrow infiltration, and rapidly progressive disease, where the lymphocyte doubling time is less than 6 months. Currently, the only way to cure CLL is a bone marrow transplant. So one of the things that we ask our patients is, how can we support your journey? So those in which we're trying to understand sort of your trajectory. How quickly are your blood counts changing? How quickly is your physical exam changing? Are you developing any symptoms? Then your follow-up might be initially quite rapid, maybe every 3 months, and then might become longer in between. And if over time things start to change and we need other appointments, then that follow-up period might be smaller. And our goal is really to prevent complications of CLL. And so as I talked about, the CLL cells start to change the balance of immune markers and other immune cells within the system. And so your body's job is to fight off naturally unwell cells in all other tissues. And so that's part of the immune system's role, and we're starting to learn more about the immune system's role in fighting cancer. And CLLs might disrupt that normal balance that is present. And so we ask that our patients get age-appropriate cancer screening, or if they develop symptoms of abnormal bleeding, abnormal cough, those things be brought up to their provider so that the risk of second cancers be addressed. The second thing is infections, and that has really affected our lives over the course of these last few years, but infections are a consequence of CLL as well. And so protecting your immune system by the regular use of vaccinations and just keeping an eye on, a general scratch or a scrape, something that isn't healing quickly. Those are all things that you need to bring to the attention of your provider. So I wanted to spend the next portion of the talk because treatments have changed drastically, and part of that is because we need to understand your CLL's specifications. So that comes by understanding the baseline in a cell that may allow it to grow continuously. And so if you don't have the balance of the brake and the accelerator, then this results in the development of a cell that grows continuously and becomes cancerous. So one of the ways we can measure these abnormalities that I spoke of in the last slide is something called fluorescence in situ hybridization, often referred to as FISH. And so the idea is the cell packs its genetic material into structures called chromosomes. And chromosomes are where specific genes live. And the chromosomes are numbered. And so we are able to identify the chromosomes by their size, and therefore detect specific abnormalities in the different chromosomes. There's 4 chromosomes that are typically evaluated in a traditional FISH panel. Now, some institutions may only look at some of the higher risks, such as the 17p and 11q, but there are 4 common abnormalities on the traditional CLL panel. And 80% of patients will harbor at least one of these abnormalities. So what do they mean? So 13q deletion is the most common, and approximately 50 to 60% of patients have these. It's known to have a good prognosis, so it's one of the chromosomal abnormalities that predicts a better outcome in patients. However, we're going to learn over time how patients with this deletion may respond to therapy directed against the BCL2 protein, such as venetoclax. The highest risk markers are the deletion 11q and the deletion 17p. And this is because both of these chromosomes harbor a tumor suppressor gene. So remember how I said, if you lose a tumor suppressor gene, you lose a break. And so traditional chemotherapy requires the function of these genes in order to work. But the newer agents are starting to we're starting to learn that they are working regardless of whether or not patients have these abnormalities. And there's certain drugs that are better, especially if you have a p53 mutation, which we'll touch on later. Trisomy 12, we're still learning about. It may be associated with a transformation to diffuse large B-cell lymphoma known as Richter's transformation, but we're still learning about the biology and whether or not it really does link to Richter's transformation. The most important thing is this is a process that changes with time. And so what you might have at diagnosis in your profile, which is often done in the United States, but less commonly in Canada, when we do this, we tend to do it closer to treatment because it helps us. The other way to detect abnormalities is actually looking for mutations within a gene. So the p53 gene lives on chromosome 17. So when we do the FISH, if you lose part of chromosome 17, you're often losing p53 gene with it. Now, some people have an intact chromosome 17, but if you sent their CLL cells for something called sequencing, and you actually looked to see whether or not there was an abnormality in that gene that rendered it non-functional, a small number of patients, about 4 to 8% of patients would have this mutation. And so in order to determine someone's p53 status, the ideal situation is that we do FISH and p53 mutation testing. And again, this is something that can develop with time and should be tested unless already known, i.e. that you already have the mutation prior to every treatment. The other test that's spoken about frequently is something called the IGVH mutation. So the IGVH mutation allows us to classify your CLL cells into a mature phenotype, which is good, or an immature phenotype, which is something where the traditional treatments that we had been using, specifically chemotherapy, may not work as well. So that immature cell is what we call IGVH unmutated. And so this allows us to help further characterize patients. Now, if we take, and why is this important? I think it's important because now we're starting to get different parts of the puzzle that allow us to look at a prognostic score, which will likely be the backbone for a lot of clinical trials in the future, but also allows us to characterize a patient's risk as a whole. And this uses things that are approved and being used right now in Canada. So the P53 mutation, the IGVH mutation, the beta-2 microglobulin, which is a biochemistry test that is used, the stage and the age. And so patients who are considered low and intermediate had a very good outcome. Now we have to understand that this study was reported back in 2016 when a lot of the novel agents we're using in CLL right now were not included in the outcomes. So I predict that these numbers are going to change drastically for those with high and very high risk disease as we are using better treatments. So what do I mean by better treatments? Well, if we look at the timeline in terms of development of treatments for CLL, there was a huge lag initially. So we were using single agent alkylating agents. Then we started using nucleoside analogs such as fludarabine. And then we combined the two chemotherapies we had together. And then we started to use targeted agents such as monoclonal antibodies, which started to revolutionize therapy, chemotherapy agent plus a backbone, as a backbone plus an antibody. Then in 2010, reports started to come of targeted agents that were directed against the survival signal of CLL. And so this allowed us to combine them with novel agents either alone, and now we're starting to see that transition where we might be able to have an entirely chemotherapy-free regimen. A lot of the targeted agents are used on a continuous basis, but some of them are used in a time-limited fashion. And so what we're going to be using in the future is currently being determined through multiple clinical trials, but it is an exciting time in the treatment of patients with CLL. So let's go into some detail about some of the agents and how they work. So in order to pick the best treatment for a patient, we often relied on their age, their fitness, and their kidney function. And this was how we selected specifically chemotherapy. And so the advantages of chemotherapy were that they were time limited and they were cost effective to a public healthcare system. The disadvantage was that patients needed to come into hospital. They had to get an intravenous, and they required nursing and pharmacy support, and obviously not just the short-term side effects, but the long-term side effects. But these agents basically worked by interfering with the, think about novel agents. They are working in a system that is specific to the cancer cell. Now, if we think about how they work, BCR targeted agents, or the B cell receptor signaling pathway, is responsible for proliferation and survival of the CLL cell. And so it's a series of proteins that are interlinked through different communication strategies that allow the CLL cell to survive. And so if we take drugs such as ibrutinib or acalabrutinib, which are directed against the BTK protein, or idelalisib or duvelisib, which is directed against the PI3 kinase protein, by interfering at either one of these steps, we end up blocking the survival and proliferation pathway. So the next class of drugs are called monoclonal antibodies. And these are obinutuzumab and rituximab, specifically in CLL as of right now. And these drugs target the CD20 surface marker, which then leads to the cell death. Obinutuzumab has been proven in clinical trials to be more effective at causing cell death in a head-to-head comparison with rituximab. And finally, the newest drug on the block is venetoclax. And venetoclax targets apoptosis. So apoptosis is a cell death mechanism. And what happens in CLL cell is, so in order to determine which treatments were best for patients, we often had to balance their toxicity rates with how well they worked. And so when we look at this figure, it basically combined all the different treatments that were available for CLL patients and the different regimens listed up here. But then it also demonstrated that as regimens became more effective, their side effect profiles also increased. And we have to take that into consideration when we're picking the treatments, and we need to have these discussions with our patients so that, you know, they are very well aware that when we talk about grade 3 side effects, this means the risk of being hospitalized or requiring an intravenous intervention for the treatments that they're receiving. And so that information has to be very well communicated to you as a patient, an important part of the decision making. Now, if we went back 5 or 7 years, we probably didn't even have options to offer. It was just these regimens, but we would pick these regimens based on, you know, which category of fitness or frailty you fell into. Now, however, we do have a lot of different treatments that are available for our patients. And this is the provincial funding algorithm for the country. And so when we look at it, the youngest fit patients are eligible for the best treatment from a chemotherapy perspective. But it, like I mentioned, it is one of the hardest ones to tolerate. And if you're not fit for chemotherapy or you have high risk factors, then your treatment options increase. And what is available to you as a patient may depend on what province you're in. And in the second line setting, you can see that we don't have any chemotherapy listed. So chemotherapy is up here, and in the second line setting, it's all access to new agents. So when we think of the different questions we're trying to address in the CLL world today through clinical trials, these are the three things that we think about the most. One is, can we improve outcomes for our patients? 2, can we reduce the side effect profile? And 3, can we stop treatments? Because there was a period of time in which the treatments that were best for patients, especially if they were older or frailer, were continuous treatments, but those treatments had a large side effect profile. So when we look at the evidence that is being evaluated in clinical trials nowadays, the treatment choices for young fit patients is definitely changing. So young fit patients, if you look at their progression-free survival, as well as their overall survival, tend to benefit from ibrutinib opposed to fludarabine, cyclophosphamide, and rituximab, or FCR. But that holds true for everybody except for a specific, I should say, subgroup of patients. And this is the IGVH mutated patients. So the low risk patient still benefits from chemotherapy. And the reason this is important is that we have 17 years of follow-up data in which a significant portion of patients actually achieved cure. And so FCR is the only way to cure CLL in that population. The newer treatments that are being developed and studied right now are for patients who are considered unfit, i.e. they have multiple medical problems, or they're over the age of 65. And so this is a study that looked at venetoclax in combination with obinutuzumab compared to the standard arm in that patient population, which is chlorambucil and obinutuzumab. And this was a treatment where we had 12 months of continuous therapy, and then it was stopped. And then what we saw was patients who were on the venetoclax and obinutuzumab arm actually have a better progression-free survival. And this data was just updated over the course of the summer, and 74% of patients continue to have a 48-month progression-free survival, compared to the patients who were on chlorambucil and obinutuzumab. The other the other clinical trial in that same age category, which is of a continuous nature, is using acalabrutinib. So acalabrutinib is a BTK inhibitor, and it's used as a continuous therapy. And so similar to the ECOG 1912 study, again, ibrutinib was used as a continuous therapy. So when patients are on a continuous therapy, they tend to do extremely well compared to those who are on a time-limited therapy with chemotherapy. And so the progression-free survival after the first data cut at 28 months was 93% in the patients with acalabrutinib and obinutuzumab, and 87% with acalabrutinib alone. If we look at the updated data, those numbers still hold, with 87% of patients and 78% of patients respectively having a progression-free survival after a 48-month follow-up period. So when we think about the treatments, we have to consider the genetic makeup that I talked about for patients. And the genetic makeup that is, I think, of most importance is the 17p deletion, or the p53 mutation. And so it is clear that patients who are on a BTK inhibitor and receiving continuous therapy do better from a progression-free survival than patients who have a p53 mutation and are on a time-limited therapy. And this is important to take away. However, when we look at other risk factors, when we take the unmutated status and remove the p53 mutation, I think time-limited therapy with a venetoclax-based regimen is also an option. But those patients who harbor a 17p deletion are probably best receiving a BTK inhibitor. So if we think about it, high-risk patients should be getting continuous therapy, such as ibrutinib or acalabrutinib, and low-risk patients who are eligible for either chemotherapy or venetoclax obinutuzumab-based combinations in the frontline setting. So when we think of minimal residual disease is the disease that's left behind after a treatment. And this is something that is actively being studied in the CLL setting. And so treatments are being designed to understand which treatments can give you the best reduction in minimal residual disease, and whether or not we can potentially make treatment decisions based on MRD. So MRD, if we achieve a good depth of response with treatment, could allow us to have a time-limited therapy, and this could considerably reduce costs for the treatments. Now, the Canadian environment has been very good at supporting CLL patients, but the reality of the situations is that we've gone from 6-month treatments with chemotherapy that cost in and around the $40,000 to $60,000 range to time agnostic or continuous therapies that are about $10,000 a month for years on end. But that price also comes with a price to the patient, and those are the side effects. We didn't spend a lot of time talking about the side effects with some of these BTK inhibitors, but I think it's important to mention that people can develop heart-related side effects, skin-related side effects, blood pressure-related side effects, and infection-related side effects. And these are things that are a patient is at risk continuously